Dear colleague, it's a pleasure today, on behalf of all my colleagues and co-chair within the French National Network on Stem Cell Transplantation in Autoimmune Disease, called MATEC, within the French Filière FAI²R, to present our experience over the past 10 years concerning the indication and the use of autologous hematopoietic stem cell transplantation in autoimmune disease. It is of utmost importance today that what has been elaborated as initially investigating study and now demonstrated with this grade A level of evidence as an effective therapy for treating several autoimmune disease, then we can put the bridge within the European network to enhance knowledge and interest about the indications for this type of therapy. We do not pretend in 20 minutes or so to review with you and all of us the incidence or the pathogenesis of autoimmune and autoinflammatory disease. However, whether we speak about Sjogren disease, rheumatoid arthritis, systemic sclerosis, multiple sclerosis, Crohn's, we know that all of these autoimmune or autoinflammatory disease have a common pathogenesis, which is based on a genetic background, the onset of any or many antigen stimulation, whether infection, toxic, or with a predominance in women during pregnancy, that will induce abnormality or at the end loss of tolerance, and therefore activation of the immune response and abnormal activation of the immune response, not only the adaptive but the innate, but also the adaptive immune response. We will not dig further in this magnificent concept developed now more than 15 years ago by McGonigal, who demonstrated elegantly that with knowing today the genetic background of all these autoimmune and autoinflammatory disease, we know that in each disease there is a component of autoimmunity and most of the time autoinflammation. And therefore that will contribute to the onset of chronic disease, which are characterized by several aspects, whether there is flare, characterized by activity of the disease, there is treatment which aims at establishing a clinical response and hopefully remission and maybe cure. However, this is a long story. How do we define the cure of an autoimmune chronic disease? We do not have the same level of evidence whether we are dealing with rheumatological disease, neurological disease, or organ-specific disease. As a concept, we remember and we all know facing our patients that those patients with long-standing chronic immunosuppressive therapy, altered quality of life, may have some kind of combined toxicity and other comorbidities, namely and specifically cardiovascular disease and infection at the front page, but that will be at high cost for both patients and society. At the end, in several diseases, and we'll focus our attention towards some of them today, we have patients who are resisting to several lines of established or validated therapy, and in some diseases such as scleroderma, for instance, or very severe form of any of these diseases, we have patients who are refractory to any types of therapy. It is in this concept that hematopoietic stem cell transplantation appeared as a new therapeutic concept for treating autoimmune disease. Indeed, 30 years ago, Ikehara had elegantly demonstrated in mice that the origin of autoimmunity is typically tightly related to the bone marrow abnormalities, and that whether we are in mice or in human, there is a relationship with the bone marrow. And therefore, it was demonstrated that the use of bone marrow transplantation Not only allogeneic but also autologous stem cell transplantation could induce remission of pre-existing severe autoimmune disease. Therefore, if this is true in animal and has been observed in several cases of patients who were suffering from both autoimmune disease and hematologic malignancy, in this concept, several of us over the past 25 years have started to treat very severe refractory autoimmune disease patients using myeloablation or intense myelosuppression and stem cell transplantation in order to reduce the duration of aplasia. In the 1994 until 2014, the first 10 years were basically progressive efforts around Europe, North America, and also China, which progressively demonstrated the feasibility of this kind of approach, and thereafter we got results from prospective randomized controlled trial which demonstrated with a high level of evidence that this approach could be of utmost benefit in severe refractory patients or before they would be too severe. The principle of using hematopoietic stem cell transplantation for autoimmune disease, in most of the case it is autologous stem cell transplantation, is based, as shown on these slides, on the mobilization of hematopoietic stem cell from the bone marrow into the peripheral blood. Then these cells are being collected and preserved in the lab until a few weeks later, not more than 3 months later, intense conditioning regimen is being applied to these patients in order to eradicate the whole autoimmune activity and to get rid of autoreactive T and B cells, and therefore to reset at zero the immune response and to induce a new tolerance. This can be performed with high-dose conditioning regimen, the use or not the use of TBI, which was not the habit in Europe but which has been used in North America. And therefore, after this high conditioning regimen, patients undergo an aplastic phase, which is being diminished by reinfusion of the hematopoietic stem cell. Therefore, the aplastic phase will last from 10 to 15 days maximum. And thereafter, within the year after transplantation, patients will progressively re-educate their immune response with recovery of a de novo immune response, and in several cases, as we shall see in a minute, true regression of the disease after resetting the immune response. It is in this concept that concerning the rheumatologic disease, systemic sclerosis, for which in 1955 no treatment was existing, and for which we know for years that this is a disease associating early vasculopathy, which will induce inflammation characterized by autoimmunity and specific autoantibodies, and therefore induce hypervascular reactivity, immune inflammation that will eventually lead to fibrosis, which is the hallmark of the disease, which affect both the skin but also internal organs, namely the lung, the heart, and the kidney, and which is associated with a dreadful prognostic. In this concept, not only through Europe and the creation of the FAI²R research group that I had the privilege to co-found with our Swiss, Netherlands, and Hungarian friend, not to forget our British colleagues, the FAI²R database has helped us in Europe to further dissect and continue today to have critical prognostic criteria for these patients. And progressively, there was more awareness. We knew which were the prognostic factors for these patients, and with the FAI²R research group and the EULAR group, better, earlier diagnosis of these patients prior to death, which was the case after 3 to 5 years when they have both skin, diffuse skin, heart, lung, and kidney involvement, was being treated. Today, as you can see on these slides, although we have tremendously progressed by using earlier diagnosis of these patients, we still have a 5-year survival of these patients when they have either 1, 2, or 3 internal organ involvement, which is dreadful, and a 3 to 5 years mortality rate, which approximates, as you can see on the right side, 30%. This was recently confirmed by several European studies, namely the one from LI published in Annals of Rheumatic Disease in 2017, and also a Canadian cohort, and all the large cohorts saw the same dreadful evolution in this disease, with a standard mortality rate which is much higher compared to the whole population. In this concept, first, early phase 1-2 studies were being performed showing the feasibility of hematopoietic stem cell transplantation, which allowed to induce early reversal of skin fibrosis, improved quality of life, and apparently longer survival, but these were early data on registry from the European Bone Marrow Transplant Association on registry studies. Therefore, it has been important to achieve progressively, this took 15 years, prospectively randomized trial, which were performed, the first one and published by Richard Burt in the Lancet in 2011, so 10 years ago, which had to stop his trial earlier due to failure to reach the equipoise. As you see on these slides, those patients who were receiving cyclophosphamide IV9 as compared to hematopoietic stem cell transplant were doing much worse, and if we compare the transplant group to the standard therapy at that time, we see that skin score, lung function was tremendously different and improved. In the same time, the European AHSCT trial and the SCOT trial, which were respectively published in 2014 for AHSCT and more recently in 2018 for the SCOT trial, used the same inclusion criteria for these patients who were having severe skin score involvement and either heart, lung, or kidney involvement, and were being compared as using cyclophosphamide IV monthly in the control group as compared to intensification and stem cell transplantation in the hematopoietic stem cell transplant group, without using TBI irradiation in the AHSCT trial, whereas the SCOT trial used lower dose of cyclophosphamide and irradiation. We see that both trials, in addition to the early phase 2 trial from Burt, evidence the fact that for the first time in this disease, this stem cell transplantation due to high dose conditioning could induce higher survival at the expense, nonetheless, of a high early morbidity and maybe mortality as compared to the control group, but starting at 5 up to 7 years, the difference were highly significant. This has led us to recapitulate the experience of 5 years ago when comparing cyclophosphamide IV towards intensification using either non-myeloablative with cyclophosphamide and anti-lymphocytes globulin, or myeloablative conditioning with lower dose of cyclophosphamide, as you see 120 milligram kilo, with in both approach the use of anti-lymphocytes globulin in order to further deplete the autoreactive remaining T cells. As you can see on these slides, the morbidity or mortality associated with these conditioning and with the selection of patients differed according to trials, and the more you treat patients, the higher the risk. but at the end, the mortality associated with these types of therapy is still 60%, which remains much lower than the 30% observed without treatment or with the current treatment, which were not and are still not effective. However, the use of irradiation can be associated with secondary malignancy at a much higher rate. As you see, 10%, 9% in the Scott trial as compared to 1.3 in the ASTIS trial, which has convinced the community that we have to improve the regimen. And it is in this concept that today in 2020, the recommendation in France and in Europe for treating early rapidly progressive scleroderma tends toward increasing the indication towards patients with diffuse disease, rapidly progressive, and the presence of internal organ involvement, and or without diffuse disease, and in some patients with a Rana skin score below 14 only if they have evidence of progressive pulmonary disease. The important aspect recently published by Bert, and that the French group on stem cell transplantation, MATEC, has developed extensively over the past 2 years, is the approach of improving our conditioning. We need to better select patients before transplant and to put emphasis on existing or not underlying heart involvement. And as you see, the use of lower dose of cyclophosphamide with or without rituximab in association with fludarabine has been associated in recent experience with lower toxicity. So to conclude on the current indication, it's been the first time in this disease that use of hematopoietic stem cell transplantation, providing that patients are correctively selected with intense investigation prior to selecting those patients who can be candidate to transplant, achieve very good results in terms of survival, improved quality of life, regression of skin, lung, and even heart fibrosis. What about the use of the same approach in other disease in the neurological field? Today in France, multiple sclerosis is the first cause of severe non-traumatic handicap in young adults. This is it is much more frequent, but it remains the severe refractory or progressive disease remains a question for treating adequately those patients who are refractory. Why? Because multiple sclerosis is a complex disease, but with the same pathogenesis, which associates as many autoimmune disease, a complex genetic background, several environmental factors and antigen stimulation, which at the end will induce a disease that may be early, preclinical, without modifications, clinical modification, that will lead to an inflammation at the neuronal level with demyelination, axonal damage, and glial proliferation, and therefore, and these are characterized by relapsing, described on a clinical point of view as relapsing remitting MS, and therefore afterwards will induce toward demyelination and axonal loss with more or less myelin or neural repair, which is no more accessible to treatment and is characterized by what is being called secondary progressive MS. It is in this context of, again, a highly inflammatory early disease progressively evolving toward secondary progression, but the evidence of CD4 T-cell mediated disease at the beginning, that the community, the neurologic community and the immunologist and the hematologist realized that in this disease also the use of hematopoietic stem cell transplant in order to reset tolerance for those patients who are refractory to first line or second line well-established treatment can be a new approach. But this should be performed prior to the handicap is too much advanced. That means before patients have an EDSS, which is the way to score the handicap, above 6, unless when we take these patients toward transplantation, they are at much higher risk of the procedure. So we do not pretend that all patients with multiple sclerosis should be candidate to hematopoietic stem cell transplantation, but there is a significant amount of those patients who, despite correctly established and treated first and second line treatment, will be refractory and continue. And it is in this concept that first in Europe we achieved a randomized trial after many years of works, comparing methotrexate on the left side towards the use of hematopoietic stem cell transplantation. And as you may see above, the change in EDSS, the handicap score before transplantation and thereafter, was significantly lower in those patients who were sensitive to hematopoietic stem cell transplantation. So you see that after transplant, there's been a significant fall, and this was the first randomized trial which demonstrated that the cumulative number of new T2 lesions on MRI was significantly lower using hematopoietic stem cell transplant. Many more experienced, very few in France, many in North America, in Canada, and in the rest of Europe, and today in Sweden, and of course in Italy with Riccardo Saccardi and Moncardi, have enabled us to demonstrate at the European level that indeed after transplantation the probability of progression is tremendously reduced in these patients, and there's no relapse event. However, in the meantime, there were progress concerning the better analysis of either the use of standard first, second, or third line of therapy in these patients using interferon beta or fingolimod or monoclonal antibodies such as natalizumab and alemtuzumab. And a new score was accepted by the community, which is based on the absence of evidence of any disease activity, with a new goal for treating relapsing remitting multiple sclerosis, which should associate no relapse, no disability progression, and no new or active lesions of an MRI. And this very important meta-analysis from Maria Piassomani and Paolo Murao shows you elegantly that if we collect all the data from hematopoietic stem cell transplantation at the end of the slides, as you see here, as compared to biologics or to first-line therapy on placebo, you can see that autologous stem cell transplantation is the only treatment so far in these patients who achieve full remission on NIDI at 70 to 80%. So more recently, the paper from Burt, who compared hematopoietic stem cell transplantation compared to other disease-modifying therapy in a cohort of 100 patients prospectively followed, clearly demonstrate that in a single center of excellence, the transplant-related mortality was 0, with significant remission of the disease. So at the end, the French group of neurologists who progressively and very slowly took interest, but thanks to Professor Zephyr and others, we progressed over the past 5 years in the MATEC group, and today we have defined guidelines that you will have access to on the website, and we consider that hematopoietic stem cell transplantation should be considered or can be considered in those patients who do not have a too advanced handicap with an EDSS score below 6, providing they have a relapsing remitting form despite second-line therapy for at least 6 months and at least one flare with a clinically significant episode, and at least one gadolinium enhancement on MRI. The question which is important for patients who suffer from progressive disease is totally different, because these patients usually fail treatment, but they may have a progressive phase less than 5 years, and on this progression may have new flare of the disease. And only on this case, if there is at least one flare with a clinically significant episode associated with one gadolinium enhancement on MRI from at least 3 months, or one significant new T2 lesions on MRI of less than 3 months as compared to baseline, then it is worth considering the potential indication from hematopoietic stem cell transplant. As a conclusion, the experiences France is progressing. We have more and more patients who are calling us at MATEC Center of Reference and in the platform to call for information concerning stem cell transplantation for MS. It is of utmost importance that within Europe we develop this approach more and more, which has been evidenced now as beneficial for well-selected patients, providing the handicap or the disease is not too advanced. What about Crohn's disease? Crohn's disease, which is an autoimmune and autoinflammatory disease associated with antigenic stimulation, predominantly digestive, of course, per definition, dissemination of the disease. It is associated with progression, relapse, and activity. Despite important progress over the past 15 years with the use of biologics, despite the fact that these patients are accessible to surgery, we have to note that 30 to 50% of them will require surgery, and at the end that the standard mortality rate is enhanced in these patients due to progressive disease and comorbidity. It is in this concept that first, under the British PI Christopher Oker, within the Europe, we started a randomized controlled trial aiming to compare 45 patients who were comparing standard therapy, if we may say so, as compared to transplantation. And the endpoint in this trial were of utmost rigor, because the primary endpoint was associating full remission clinically and endoscopically. And therefore, as we see here, although the primary outcome as initially defined was not achieved, the secondary outcome, which was no activity of the disease, was achieved, but not on the primary endpoint. This is the reason for which in this early trial a secondary analysis of those patients who were included in the AHSCT trial was performed to further analyze the endoscopic remission. And as you see here, complete endoscopic healing and partial endoscopic healing was achieved in a significant number of patients when being transplanted early as compared to late. So although the early clinical trial published in JAMA was negative in terms of primary endpoint, it was possible to demonstrate that complete endoscopic healing was achieved in 19 out of 38 patients, and that the primary outcome, which should encompass shorter disease duration and low baseline CDI, can influence the outcome after transplantation. So there are some patients who are at high risk and or who are at failure from any further treatment, and therefore what we know is that today autologous hematopoietic stem cell transplant should be regarded as a salvage therapy in some of these patients who are resisting to all first, second, and in the absence of potential surgery. So these patients who have active disease and they should be refractory to previous immunosuppressive drug, and surgery should not be feasible. As a conclusion, who should be considered as a potential candidate for hematopoietic stem cell transplant while suffering from autoimmune disease, and how to proceed in 2021? This is the organization we have set up in France within the MATEC network, Stem Cell Transplantation and Cell Therapy for Autoimmune Disease, and you can have access to all details on our website platform. Not only to consider a potential disease in a patient with early organ involvement and disease progression despite first and second line therapy, but also after considering very detailed patient selection, which necessitate full and early detection of internal organ involvement in order to rule out any contraindication, and also to bring the patient to the transplantation. This requires working in collaboration within several experts within a network, and at a certain point to have a multidisciplinary evaluation of the case in order to validate the indication, to confirm the absence of contraindication, and to address the patient from his original expert center for his autoimmune disease to the expert center accredited for allogeneic bone marrow transplantation in order to be able to perform the ad hoc conditioning regimen and using lower toxicity. For this, over the past 20 years, we have worked in collaboration at the national level, the European level, to establish guidelines which are accessible and can be shared using multiple approach and combined expertise. I want to thank the patients who most of the time come on their own, to thank the colleagues of the network and the Filière and the reference center, which has enabled us from 5 years ago to establish this very useful network that will extend towards the European Network of Excellence and the European Bone Marrow Transplant Association. Thank you.